So without further ado, I would like to introduce Dr. Samuel Frank, who is a movement disorder specialist here at Beth Israel. He's been with us for about a year and a half, and he's going to talk to us about the non-motor symptoms of Parkinson's disease.
Well, thank you for coming out on such a snowy April 1st. I think it is nature's April Fool's joke for us. And the last snowstorm was 20 years ago, I heard in the paper today. I remember the day vividly because I was a medical student and I was on my surgery rotation and I couldn't get to the hospital, so I panicked. It was only compounded the next day when I found out my chief resident cross-country skied to the hospital, and so she was there. I have left plenty of time for questions since this is Ask the Expert. This isn't listen to the expert talk for an hour and a half. Just to give you a little bit of my background, I've been here for a year and a half, but my work with Parkinson's disease actually goes back a fair ways. I spent a year in between college and med school in a lab similar to what Lauren is doing and Elizabeth will be doing. And I studied sleep. And when I got to medical school, I studied people with Parkinson's disease and what kind of sleeping problems they had. That led to my interest in neurology and movement disorders. And then during my fellowship at the University of Rochester between 2002 and 2004, I spent half my time studying Parkinson's disease and really the non-motor aspects. So fluctuations and mood fluctuations specifically is what I spent some time, as well as some ethical work related to Parkinson's disease. So that's just my background, a year and a half, but I've been dealing with Parkinson's disease since 2002. So I suppose that's what qualifies me as being an expert up here. Just some disclosures. We're going to be talking about different interventions and drugs. I just want to make sure you all know I have no direct ties to pharmaceutical companies. I'm not paid by any. I do have some grant support by Teva and the Michael J. Fox Foundation, and I'm not going to do anything foolish today. I want to start off with how we diagnose Parkinson's disease because I think it's really important to keep it in mind. The definition is really evolving in terms of how we diagnose Parkinson's disease, but it really is focused on the motor aspect. I'm a neurologist, but I'm a movement disorder neurologist. So I focus on the movement side of things, but that's really not everything that I do. And so today, I'm going to briefly touch on how we diagnose Parkinson's, and then we're going to talk about everything else. So we diagnose it based on the presence of a rest tremor, so not just any type of tremor, but when a limb, and typically it's an arm, is at rest. It's at its most relaxed point. There are other types of tremors that we help to differentiate, but the rest tremor is one of the hallmarks of Parkinson's disease. When I'm watching someone in the office, from the moment I lay eyes at them, I'm also looking at their spontaneous movements, their slowness. So if they are this is both from a formal perspective, and I'm sure everyone in Parkinson's disease has done this type of thing, right? So that's assessing some of the slowness, but it's larger than that in terms of a bigger picture. How much gesturing is there? If there's someone who's right-handed and they have Parkinson's disease, are they gesturing only with their left hand? So these are the things that I'm looking for in terms of observation of the bradykinesia, or slow movement, as that translates to. And then stiffness or rigidity is also a hallmark of Parkinson's disease. And all of these symptoms typically start on one side. They certainly don't have to, but they commonly do. So these are the criteria that we use to diagnose Parkinson's disease. And so you can see that all of this is focused on the movement, on the motor side of the disease. And this, along with the progression, as well as lots of other issues that people talk about, or how we diagnose it, we also want to make sure that there aren't any other factors that can contribute to a Parkinson-like picture. So, for example, there are movement disorders where the eye movements are not normal, and that can be very early, and it really does take a good movement disorder neurologist to help sort out what's normal and what's not in terms of eye movements. We're about to get started with a project to use a very non-expensive device to look at eye movements. And we're going to start off in diseases where we know the eye movements are not normal. There's a larger project going on in Virginia looking at eye movements in Parkinson's disease to help differentiate Parkinson's from other Parkinson-like diseases. Whenever people have dystonia, which is an abnormal posture, increased muscle tone that's above and beyond the rigidity that we see in typical Parkinson's disease, it also may be a clue. Perhaps this is something else in the context of everything else. Particularly young onset Parkinson's disease, people can have dystonia, and it's common to have dystonia over the course of Parkinson's disease, whether it's foot turning in, toes curling, eyes squeezing shut, or the neck being in a dystonic posture. So these are all very common in Parkinson's disease, but when it's very prominent and involves half the body or most of the body, then we really have to question, is this Parkinson's disease or not? If there are blood pressure issues, and almost everyone with Parkinson's disease has blood pressure issues. When they stand up, the blood pressure can drop down, but if people a year into the course are standing up and passing out because their blood pressure drops from 150 systolic to 60 systolic and they can't maintain perfusion to the brain, that's another clue that perhaps this isn't Parkinson's disease, that we should be looking at another disorder. And this last exclusion criteria is really a point in evolution. There was a revised criteria for Parkinson's disease that does include hallucinations and dementia early in the course, meaning within the first few years and not related to medications. And this gives us a clue that perhaps people that have dementia can have some Parkinson's signs. So a third of people with Alzheimer's, for example, have slowness, stiffness, and 10% even have tremor. So that is not a separate process. It can be part of Alzheimer's. Dementia with Lewy body or Lewy body disease is another disorder that we think about. That this is why this last criteria is under discussion, because that's the same pathology in terms of the brain. It's just that it hits different areas at different times. So this is something that is a point that's under discussion and evolution now. So we make the diagnosis based on the story that people tell me in terms of the progression and some of the clues to get at slowness and stiffness. I'm having trouble getting my arm behind me in a jacket, having trouble getting out of a couch. I can't coordinate my two hands with movements like cutting a tough piece of steak, something like that. So those are the types of motor questions that people tell me, and I'm looking for those subtle signs as well, or sometimes not so subtle signs on exam. So it's really truly based on the story that people give me as well as the exam, which makes a difference in terms of who you go to, because the person who's examining you and getting that story needs to know what questions to ask. So it does make a difference, and of course I'm biased because I'm a movement disorder neurologist, but there are many studies that do support the fact that you're in better hands, both in terms of diagnosis and long-term quality of life, if you have a movement disorder neurologist who's involved in your care. That doesn't mean that they have to be the primary person. If they're a 3-hour drive, you can certainly work with a local neurologist, but checking in once a year is something that some of our patients do, and then work with a local neurologist. So in terms of diagnosing folks, movement disorder neurologists are right about 95 to 98% of the time. General neurologists in one study were about 80%, and internists about 50%. This is in early Parkinson's disease. We are still working on a better way to diagnose Parkinson's disease compared to what James Parkinson described by observation in 1817, 200 years ago. But as we sit here today, there really isn't a lab test, MRI, CT scan, PET scan, X-ray, or biopsy. There's nothing that's directly available to say, well, I think you have Parkinson's, let's draw this blood test and confirm it like we have with other disease states. And so sometimes we do these other tests to rule out other diseases. So if I'm concerned that somebody may be having small strokes that can lead to some symptoms similar to Parkinson's disease, we might do a CAT scan or MRI depending on the situation. That's the type of situation where we might do that. I do want to mention DAT scan. DAT scan is an agent that we inject, and 4 hours later the SPECT cameras, SPECT is like a low-level radiation PET scan, and it's commonly used in oncology. It's becoming more common in certain neurological diseases as well. And what we get is a picture that looks a little like this. And so you can see that on the left side of the screen is a normal DAT scan, And it looks like a comma in terms of the areas of the brain that use dopamine. And this is what we are looking for, is that normal, bright comma type of picture. And you can see that there's diminishment on the right side. There's a little bit of a loss of the tail on both sides, and one of the heads is not as bright as the other. So there's a loss of signal there. And so that asymmetry, that lopsidedness, as well as the loss of the tail, is what radiologists will say is consistent with a Parkinsonian syndrome. And so they can't diagnose Parkinson's disease based on a DAT scan. And there are many Parkinson-like diseases or Parkinson lookalikes that can also have an abnormal DAT scan. And so that's why they can't say definitively this is consistent with Parkinson's disease. They will only say a possible Parkinsonian syndrome. So and there are about 15 to 20% of people with classic Parkinson's disease who will have a normal DAT scan. And so what do we do in that case? And sometimes that's people who are very early in the course of the disease, maybe tremor predominant. Perhaps we thought that they have Parkinson's disease, but we have to watch them over time to see, does it develop into Parkinson's? And I've had one patient who initially had a normal DAT scan, a couple years later had an abnormal one. So I think that this is still a tool that is early in terms of its development. It's been around for 5 or 6 years at this point in terms of clinical use. We've been using it in the research setting for much longer than that. And before DAT scan, we were also using beta CIT. It's the same technology, but beta CIT was a little bit more cumbersome to use. So as I've said, it's notable that we base the diagnosis on the motor criteria. We listen to the story, we look at the exam. Perhaps we might do a test to rule out something else. In some cases, we might do a DAT scan. But what we really focus on, and once we have good control of the motor issues, and what I listen for, especially early in the course of the disease, are issues that have very little to do with the motor side of things. And so this is what I want to focus on today. We're pretty good at addressing the dopamine-based aspects of Parkinson's disease. A lot of that translates to the motor side. We're not perfect. We have a long ways to go. I'm not saying that we're there, but there's a lot of work that's going on. But if there's something that's dopamine-based, and in Parkinson's disease, that's the main neurotransmitter that's low in the brain, we're okay. I think that a lot of these may be dopamine-based, but a lot of these may not necessarily be dopamine-based. So I want to touch on all of these. Sleep, of course, I put at the top of the list because that's been my personal interest and my background. I think it's also an avenue that a lot of doctors, they're a little reluctant to go into because sleeping issues can be so common, and as soon as they ask, so how do you sleep, that can open up Pandora's box sometimes. But that also can go along with mood issues, with anxiety. People with Parkinson's disease also may have issues with vision, the bladder and bowels, skin, smell, dizziness, joint pain, weight loss, sexual-related issues, drooling, memory or dementia issues, and impulse control. So some of these may be related to the dopamine aspect. Almost none are related to the movement, but they can be. So I just want to go into some detail on each of these, and then we'll open up the floor for questions. So sleeping issues are not new. In fact, James Parkinson described in his essay in 1817, he said, tremor may occur during sleep, augmenting until the patient wakes up. So even he noted that there are certain aspects of Parkinson's disease that may disrupt the sleep. It was in 1982 and 1988 that there was even more focus on sleep as part of Parkinson's disease, and there were reports of up to 98% of patients with Parkinson's disease having some kind of nighttime sleep disruption. So it's very, very common. And it is more significant, and there was another study comparing Parkinson's disease to other disorders in terms of any sleep disruption. And in this study, there were 60% of patients with Parkinson's that had some kind of sleep disruption. Diabetes, about 45%, which is another chronic disease, and healthy, quote, elderly, 33%. So there is something specific about Parkinson's disease that it disrupts the sleep, and it can be in multiple ways. And so these are some of the more common sleep disorders in Parkinson's disease. Insomnia, I think, is one of the few that we focus on. And insomnia is not just a problem of falling asleep. That can be an issue for some, but that is not typically the issue. More often, it's the second two types of insomnia. Maintenance insomnia, meaning awakening during the nighttime and inability to get back to sleep, and early morning awakening. And so people can wake up at 2, 3 in the morning and be up for the day. And that can be quite disruptive for the household, for bed partners, and for patients that have it. And so all of those can be part of the Parkinson's disease by itself, but we always have to keep in mind, is this Parkinson's or is this due to another factor? Is there an orthopedic issue? Is there a prostate issue? Is it due to depression? And so that's a pretty significant issue to address, because people with depression can also have early morning awakening. So are they getting up early simply because of the circadian rhythm shift from Parkinson's disease, or is the patient sitting in front of me depressed and needs that addressed as well? Periodic limb movements of sleep. If we break this down, it's periodic, meaning that it's regular. So sometimes it's every 20 seconds, and it's usually the leg that will kick. So this is often the bed partner that will say, he's kicking me in the middle of the night. And it's not on purpose. This is in sleep, and it's one of the known sleep disorders. It's almost always in the legs. It can involve the arms as well. But when bed partners are saying that their person with Parkinson's in the bed with them is kicking them, it often is referring to REM sleep parasomnias. So REM sleep, rapid eye movement sleep, is where 80% of dreaming occurs. And usually there is a disconnect between the active brain during REM sleep and the body. So the body, there should be a firewall that comes down that blocks those impulses from the brain to the body. And it's actually, the other name for REM sleep is called paradoxical sleep, because the brain is most active, but the body should be most relaxed. So there should be this disconnect. And in Parkinson's disease, the brain is still active and dreaming, but the body may not necessarily be disconnected. And so there can be acting out of the dreams in some fashion, whether it's talking, laughing, shouting, or movements of the limbs. And in its most severe form, people can either attack or involve something nearby, whether it's a table, a book, a bed partner, a sheet, something like that. People can also fall out of bed because of this, because of the level of activity of acting out their dreams. In its most mild form, it can just be that they're a little stiffer than they should be during this REM sleep when they should be most relaxed. But it also can be pretty easily addressed. And so I think that that's something to ask about. And it can also occur years prior to the onset of Parkinson's disease. Circadian rhythm disturbances, I think, can be a common disorder, but it needs to be asked about the right way. So what time do you go to bed? 10 o'clock. What time are you up at? 2 o'clock, and I don't nap. But then you start going into details. Well, what time are you actually falling asleep? Well, I'm kind of falling asleep right after dinner around 7, 8 o'clock and then finally at 10 o'clock, my wife nudges me and I have to go up to bed. So there's this shift so that instead of the 11 to 7, there's a shift of a few hours earlier. So people are going to bed. There's this biologic drive to fall asleep earlier, but also to wake up earlier. And that's pretty common in Parkinson's disease. It can be very difficult to address. One of the two major influences on circadian rhythm are light and exercise. And so this is not a talk on exercise, but I do hope that all of you incorporate exercise into your lives in some way, those with and without Parkinson's disease. And one of the ways to delay your sleep cycle is to be exposed to light later and to have exercise later in the day. It's pretty common for people to get up. They're up at 4 in the morning anyway, you might as well work out. It does help, obviously, to get the day going, and that's a convenient time. But if that circadian rhythm advancement is a real issue, then shifting when you do certain activities that can have an influence on your circadian rhythm may be helpful. Dystonia can happen at times of low dopamine in the brain, and that is pretty common early in the morning. And so that can be an aspect that can disrupt early morning sleep. Now, excessive daytime sleepiness or hypersomnolence, that can be from Parkinson's disease by itself because you're not sleeping at nighttime. Either the sleep is disrupted or you're up since 2 in the morning, or it can be a side effect of medications. And this is something that we do have to ask about with anyone who's on a pro-dopamine medication, especially dopamine agonists. So those are the pramipexole, the ropinirole, and rotigotine medications that are more known to have some excessive sleepiness, particularly in higher doses. But any medication for Parkinson's disease can contribute to it. And some people can't really put their finger on what is going on with their sleep. They just have poor sleep quality. And so we have part of our interdisciplinary team here, a sleep neurologist who has an interest in movement disorders. And there's a specific clinic here for people that have one or more of these that the movement disorder docs need a little additional help on or sometimes need a sleep study. Okay, moving on to mood disorders in Parkinson's disease. Up to 25% of the general population suffers from depression. So I think that that's an important figure to keep in mind, that depression in general is very common. And if you look at people with Parkinson's disease, if you classify it beyond just a depressed mood, but actually meeting criteria for either depression, minor depression, or subsyndromal depression, this can occur in up to 50% of patients. Now, I also put on anxiety in here. I'm going to talk about that as well. But depression and anxiety can often go together. So dopamine is a chemical that's involved with Parkinson's disease. It's also one of the main chemicals that we know can be impacted as a cause for depression. There are certain medications that lower dopamine in the brain, and depression is a known side effect in those medications. And so the goal is to increase depression, but will just simply increasing dopamine, will that address mood? And often not. And so the picture is more complex than just treating Parkinson's disease. And this is also beyond the diagnosis. There's clearly in some people an acute reaction to hearing bad news. And sometimes if they don't expect Parkinson's disease or it's rather sudden in terms of their life-changing events, there can be some adjustment disorder. We're not talking about that in terms of the mood disorders associated with Parkinson's disease. In a disease that lasts decades, sometimes this can be prior to the onset of any motor symptoms, and it can be long into the disease as well. So it can really happen any time in the course of Parkinson's disease. And we treat it not only by increasing dopamine, which we're going to do anyway because of the medications that we use, but also standard medications and talk therapies that are so commonly used for depression and the depression syndromes. In terms of anxiety, again, it can occur independently or it can occur in the context of depression. And we also address this in very standard ways, whether it's addressing the other aspects of Parkinson's disease or by the standard medications that we have, as well as talk therapy. And this is also where cognitive and behavioral therapy can be helpful to incorporate. Now, anxiety in particular, when it gets ramped up, can exacerbate the other motor signs associated with Parkinson's disease. So sometimes it can be difficult to tease out, is this worsening of Parkinson's disease, or is this the development or worsening of anxiety? There are many treatments that we can use for this, both pharmacologic as well as behavioral aspects, but it can certainly be a significant issue in people with Parkinson's. Vision. This is something that, along with smell, really, during my fellowship, took a lot of asking about because it wasn't something that I was aware. Often people kind of describe that they just don't see as well as they used to. They go to their eye doctor, their prescription is just fine, their retina looks okay, there's no issues. Occasionally people will come in and they see double in certain situations, but that's rare. But most commonly what the issue is reduced contrast vision. So there's a reason that I use the colors that I do for my slides, because the best contrast vision is yellow on blue. And so that's why I changed the color specifically when I give talks to people who may be impacted by Parkinson's disease. Because if you look at a standard newspaper, it's kind of an off gray on an off white. It's not pure black on pure white. And it's also, generally speaking, relatively small. In terms of the print, I know that when you get newspapers through a tablet or through your computer, you can change the size, you can change the contrast, which has really been remarkable. Along with a lot of the e-readers, you can really change the contrast and size. So that's dramatically changed the way people read. But changing the colors can also improve contrast. So if you go to a sporting goods store and get yellow tinted bicycling glasses, for example, that cyclists use outside, or go to one of the home improvement stores and get yellow tinted glasses to protect. I mean, we're not talking a major investment. It can really improve your vision. And if that's the case, then if you wear glasses, you can have yellow tint put on your glasses as well. So contrast vision really can impair the vision more than anything, but these people often will come in and say, you know, my vision just isn't as good, and then we have to do some more digging. Bladder dysfunction, Parkinson's disease, it's pretty common for people to have urgency and frequency, so they need to get to the bathroom, they need to get there now, and they're going much more often than they ever did. This can happen, again, in the early stages or anywhere throughout the time that someone has Parkinson's disease. And one of the things that I look at are people's medications. When people have a lot of other medical issues, especially high blood pressure, there can be use of medication that's a diuretic that makes people have to go pee. And that may be necessary for your blood pressure. There are other choices rather than that. And someone who may have other mobility impairments, whether it's from orthopedic issues or related to Parkinson's disease. Always, if it's just the Parkinson's, then we may be able to get at it through autonomic dysfunction, meaning there's 3 different nervous systems in our body. There's the motor system that goes from the brain out. There's the sensory system that goes basically from the skin in. There's also the nervous system that controls automatic functions. So these automatic functions are things like the pupils, the gut, the rhythm of the heart, and the bladder. And that can be impacted in almost everyone with Parkinson's disease, but to different degrees. And so if there's more widespread autonomic dysfunction, then I would expect some bladder dysfunction in someone with Parkinson's disease. And of course, decreased mobility in general can contribute to that sense of urgency and sometimes incontinence as well. Now, as far as the bowels, I can tell you that as a neurologist, I never thought that I would deal with so much constipation or GI issues, but it's pretty common. And so what I show here is a slide of the biopsy of the large colon, and all that brown stuff is staining for alpha-synuclein. The same abnormal protein that builds up in brain can also build up in the colon. And there's a lot of work that's being done now. Can we diagnose Parkinson's disease or look at people who may be at higher risk for Parkinson's through colon biopsies by looking for this abnormal protein accumulation? So that's one aspect in terms of the bowels, but on a much more practical level, people can have constipation. And there are many factors that contribute to it, whether it's decreased drinking of liquids because they don't want to have to run to the bathroom, or decreased activity. So those are the 2 main things that can actually really help with constipation. Increasing activity, so another plug for exercise, and drinking enough fluids. This is where also people rely on a little bit of coffee to help stimulate things, and that's just fine. If the usual methods have been tried, increasing water and fiber by itself will not help with constipation. It has to go with water. Then we can go with other methods like medications, over-the-counter stool softeners or mild stimulants. If that's not helpful, then I refer to my GI colleagues. But clearly the gut is very involved in Parkinson's disease. And as I said, I spend a lot of time talking about constipation than I ever thought I would as a neurologist. Skin, And skin can be impacted in multiple ways. There can be kind of an oily texture to the skin with some flakiness, and that's what we call seborrheic dermatitis. There can be some creams. There was a great cream that was on the market about 10 years ago, but it got taken off the market. I don't know what happened to it. So I haven't seen anything that's been dramatic since then. People with Parkinson's are at increased risk for melanomas, and so having a good skin check once a year is important. It's in general, it's important, but it's even more so for people with Parkinson's disease. And there was one study that suggested that people with melanoma are at higher risk for Parkinson's disease. So there is some type of connection between melanoma specifically and Parkinson's, not the other type of skin cancers, whether it's basal cell or squamous cell. Smell, and this is one of the aspects that is under more intense study long-term to see if people have reduced smell, are they at higher risk for Parkinson's disease? This can happen years prior to the onset of the motor aspects, and most of what we taste is actually smell. So I think most of us have had the experience of having a cold and a plugged up nose, and the food just doesn't taste the same. It's not that your taste buds also have a cold, it's that you're not smelling. And so this can happen years before and can really impact quality of life and reduce the ability to enjoy food as much as in the past. This is also, if you're not enjoying food, you may not have the drive to eat. It can impact weight and your appetite. Dizziness, and there can be lots of different kinds of dizziness in general. I can tell you that we see people all the time in our general neurology clinic. Probably half the consults why people come to see us is for dizziness, whether it's from an inner ear problem, a vague sense of lightheadedness, or a drop in blood pressure. And a drop in blood pressure when people go from lying to sitting to standing, that's what we call orthostatic hypotension. So there can be a drop in blood pressure specifically in Parkinson's disease without any medications, but it also can be exacerbated by the medications that we use to treat the motor aspects of Parkinson's disease. And so we sometimes can reduce the dose of our dopamine medications, and sometimes we need to add in other medications that can specifically address orthostatic hypotension. This is also where moving a little slower can be a benefit, because going from lying down and sitting up, waiting for a minute for that dizziness to resolve, and then from sitting to standing and don't walk, just stand for a minute, waiting for it to resolve, that can be quite helpful. Compression stockings, and there are all different kinds of compression stockings that are out there. I learned from my mother-in-law about one particular brand that goes from the ankle to the knee, so it's a little easier to get on and off. So I've passed it along to my patients, and I've used that myself for some road races that I've run. So those are the types of things, as well as keeping the head of the bed up when you sleep. So usually either putting cinder blocks under the bed so it's all the way tipped up, or just putting a wedge under the mattress. More pillows isn't going to do it. You got to tip up the whole bed. So if your body never gets flat, then there's not that change. So that's one of the other aspects that we can do. And this is also a situation where we really encourage people to eat a lot of salt. And usually people are very excited to hear that as a treatment for orthostatic hypotension. That, of course, has to go with water. Salt and water follow each other. So if there's dizziness, that's one thing to consider. Weight loss is something that we really do pay attention to in Parkinson's disease at all stages. We don't like people to lose weight because, at least if they're not purposely trying to lose weight, I should say. If people come in and they've lost 10 or 20 pounds in the past 6 months or a year, sometimes that's a sign that maybe their smell is off and they're not eating as well. Or maybe their swallowing isn't as good. Or maybe they really need an hour and a half to eat and they only have half an hour. So there are many reasons why people can lose weight, and so that's just the tip of the iceberg, and we often need to dive a lot deeper to look at what's behind that weight loss. Is someone exercising excessively? That happens occasionally. So these are the types of things that we need to dive into and look into. Most concerning is when swallowing is involved. So if swallowing is off, people are not as comfortable eating. Perhaps they know that and they're either cutting themselves off at the meal, or whoever is with them for that meal may say, maybe you've had enough, give it a break, give it a rest. And that's where we rely on our speech and language pathologists, and we have a great team here that can help address that. I think sexual issues are not discussed very commonly, but it is being explored more both in men and women. Dysautonomia, so the autonomic nervous system can impact function, physical function, and so that's obviously an issue. If there's decreased libido, decreased sexual drive, that can be from depression by itself or from the depression medications that may be used for other reasons, whether it's anxiety or depression. And there can be the opposite issue as well. So some of the dopamine medications can increase the drive. One of the first patients I ever had as a fellow was a patient who was hospitalized because he was using so much Viagra and that he caused some liver issues, and he was using so much Viagra because he had too much of a dopamine medication that was causing excess sexual drive. So it can be both ends of the spectrum when it comes to Parkinson's disease. Drooling in Parkinson's disease, it can be problematic for as many as 75% of Parkinson's disease patients. It's more common when people are in that off state, slow to move. And it's not because people with Parkinson's disease make extra saliva. That's not the issue. It's really secondary to overflow. So just like there's slow movements overall, there's slow blinking, we automatically, usually, will swallow to clear the secretions from our mouth. People with Parkinson's disease may not do that as often as they should, and so the saliva pools in the mouth. And so even though it's in about 75% of patients, if you ask, maybe it's a little puddle on the pillow at nighttime, that's not so bothersome. But 20% of people with Parkinson's can consider this a socially disabling aspect of their Parkinson's disease. And we can treat this with either increasing the motor aspects, because again, this is from kind of slow movement, and so sometimes just increasing the medications for the motor aspect can help, but sometimes you can give medications specifically to reduce saliva. Now, many of them have side effects in terms of cognitive side effects, and so if that develops, that's more disabling than drooling, certainly more disabling than having a handkerchief with you. But it's also a place where we can use therapeutic neurotoxin injection. Excuse me, medications like Botox can be injected into the salivary glands to reduce the amount of saliva that's produced. But you have to be careful because, again, this is not excess saliva. This is just a delayed clearing of the saliva from the mouth. And dementia in Parkinson's disease, and typically when we talk about dementia, we're talking about the surface of the brain or the cortex kind of dementia. And this is typically later in the course of the disease. If this is early in the course, or this is the presenting symptom, and then people develop signs that look like Parkinson's, this is often where we have to consider another diagnosis, but it can be an issue. Now, when you read about dementia in Parkinson's, you might see that 75 to 90% of people with Parkinson's have dementia. Neuropsychologists classify dementia in different ways. I think if you're talking about the surface of the brain, the cortical type of dementia, the Alzheimer's type, that is about 20 to 30% of people. So it's not the vast majority. Most often it's what's called the subcortical type of dementia. And these are the brain structures that are involved in Parkinson's disease as well. So it's no surprise if there's slow movement that there also can be some slowness of thinking. There can be a delay in terms of getting speech from brain to mouth. And this is what's considered the subcortical type of dementia. The memories are there, they just take a little bit more prodding or a little bit more time to get out. Sometimes it can be secondary to decreased motivation as well in terms of participating in some of the tests or in situations. Because of the area of the brain that's involved, sometimes people have attention deficit-like symptoms, and so being distractible can be part of this issue as well. And poor memory, but again, this is not just the absolute recall. If I give people prompts, for example, if I tell them to remember 5 words, and a few minutes later I ask, how many words do you remember? They might be able to remember 1 or 2, but I give them minimal prompts, they may be able to come right up with it. So it may seem like a poor memory, but with minimal prompting, it can become, the memory can come back. Impulse control disorders or excessive behaviors. This is typically a side effect of pro-dopamine medications. It's classically described in the dopamine agonists. Again, pramipexole, ropinirole, and rotigotine. And it can present as excessive thoughts alone, always thinking about something when they really shouldn't. And that's the compulsives, the obsessions. The compulsions are acting it out. So if you're always thinking about something like gambling, I really want to get to Foxwoods, I really want to get to Foxwoods, when you know it's not possible, it's not feasible, you really shouldn't, but it's something that you always think about. But then there are people that will say, well, I've got a few hours, I'm going to just sneak down to Foxwoods and gamble a little bit and come back. And so some of the more common examples are gambling, sexual behaviors, excessive eating, and intermittent or excessive internet use. There can be many others as well. I've had people that have had the excessive drive to wash cars in their driveway, or chop wood, or bake. So we put together a paper a few years ago of lots of different examples, and there are many, many different ways. I had a gentleman who started collecting baseball cards or did construction. That guy his wife was very happy that he finally completed the deck on the back of his house, but it was all he could think about for a long time. So these excessive behaviors are there, and it's not just people getting stuck on something. It really interferes with their social life and their everyday functioning. And so we can address this usually by backing off on the medications. Sometimes we have to add in other medications. Now, a lot of times we are focused on the environmental changes that we can address, or backing off on medications, or making adjustments to Parkinson's medications. But I think that the pharmaceutical industry is also starting to recognize the non-motor aspect of Parkinson's disease. And today there are 3 FDA-approved medications for the non-motor side of things. Rivastigmine is FDA-approved for dementia associated with Parkinson's disease. Pimavanserin is approved for psychosis, meaning hallucinations and fixed abnormal beliefs in Parkinson's disease. And droxidopa is approved for orthostatic hypotension. There are others that are in development and that are hopefully going to emerge in terms of treatment of the non-motor aspect of Parkinson's disease. So in addition to the motor aspect, I think the medications that we have to think about are for the non-motor if we can't address them through other means. So just to wrap up, to then move to your questions, Parkinson's disease is still diagnosed as part of a movement disorder, and this is common by a neurologist and also by a movement disorder specialist. We're pretty good, but not perfect, at addressing the movement aspect, but there are so many other aspects to Parkinson's disease that we need to assess and that we potentially can treat. And hopefully, as we gain better understanding of the disease, we can also increase our treatment options, not just pharmacologic, but non-pharmacologic options as well. So with that, I think I will stop. Thank you for your time and attention.